of, or what Aunt Susie died of, or something.
Right.
And there's a tremendous association with ovarian and breast cancer in first-degree relatives, mothers, sisters, aunts, etc. So if anyone can find out their family history and determine if they have any of these comorbidities, and a lot of these are genetically mediated with the BRCA gene that is actually an inherited form of breast cancer, and these people should all be monitored at an earlier age.
Right. They have found that the BRCA1 and the BRCA2 are mutations, genetic mutations passed down that give you a higher probability of getting breast cancer. You're considered more of a higher risk. We classify people into low risk, moderate risk, and high risk. And high risk is a 20% chance that you may get breast cancer. And in those patients, you usually do start screenings a lot earlier and a lot more frequently too.
That's correct. And if they do
I think we lost Dottie.
then they move on
there
to
you
a
are.
diagnostic mammogram, which it takes longer. It takes a different skill in terms of the radiologist. And
Correct.
it depends on the number of these diagnostic mammograms they do in a setting.
Correct. It is really important to have a skilled radiologist, an interventionist to continue the studies. In some cases, when it's a suspicious sign on the mammography itself, they'll go ahead and order also an ultrasound to try and get a better diagnostic of what they're seeing on the mammography, the mammogram. But it is important, like you said, genetic mutations of the BRCA1 and 2, the hereditary component, a family history of either breast cancer, ovarian cancer, a history of radiation to the thorax can also put you at a greater risk of getting breast cancer, correct? Oops, I think we've lost Dottie. As we're talking about breast cancer and colon cancer today. Women are not the only ones that are susceptible to getting breast cancer, although in men, breast cancer occurs in probably less than 1% of the population. And usually it's found when a man palpates a lump in the areola or in the nipple area. Hi, Dottie, are you back?
I'm back. I just went away for a minute.
Okay. I was just following up a little bit, talking a bit about, who the genetic mutations, the family history, and I also just went in a little bit of history, a little bit of male breast cancer as well, although it's not as common at all in men. So in those 40 and up, usually it's a determination between the doctor and patient of whether they give a recommendation to start screening for breast cancer, and it has a lot to do with your family history as well as the genetic mutations. So you were telling us, Dottie, about going on for further screening when they find a suspicious area in the breast?
Yeah, normally if they find a suspicious area on a screening mammogram, and once again, you do get false positives depending on the density of the breast tissue, then they will order a diagnostic mammogram, which is more films, more views, and if that still remains an issue and they have a site, they will normally do what's called a fine needle biopsy,
right,
which is painless. They take a couple samples from the site, and then that's looked at by a pathologist to determine if they do indeed have suspicious cells. If they're, and at that point, they can do some staging of the tumor type itself.
Correct. That's very correct. And of course, obviously, as I was mentioning, that sometimes the radiologist will also ask for an ultrasound if they need to get a different kind of study done to determine what kind of lump they're seeing, what kind of mass they're seeing, if it's could be a cyst or a solid type of mass, which would be a tumor. As far as the screenings go, I've seen two different schools of thought, that you can give them yearly or biennially. I can't say that word, I'm sorry. Every 2 years. Which do you recommend doing?
I think it depends a lot on your family history and your personal level of comfort. I'm a fan of annual mammograms, and I know now a lot of the different groups are moving back to doing them biannually. But I think it depends so much on the individual.
And in the case of, there's a lot of people that have had either reconstructive surgery on their breast because of prior cancers, or have just decided to get implants, breast implants. What kind of tests do they need to do? Do they also do the regular mammogram yearly? Do they have to take different views of the breast to be able to see the breast better? What are the risks, do you think, for having implants?
I personally think implants are risky from several different standpoints. With the breast augmentation, you displace normal tissue. It's an invasive procedure, and it makes the screening mammogram almost impossible. They have to then, on those patients, you do as a routine a diagnostic mammogram, which is a longer test. It does expose them, although very little, to some more radiation, and it really needs to be performed annually, even in a younger population.
Correct, and they do have to get more views because it does make it harder to see the regular breast tissue. It complicates the issue a little bit of being able to see the complete breast when you have the implant there. Some people worry that the implant might pop when they're doing the mammogram. Have you ever heard of an implant rupturing during a mammogram?
I've never heard of an implant rupturing during a mammogram, nor do I know the statistics on that. But I will say that a rupture of a breast implant is not altogether uncommon.
Right, and I have seen patients that they have had ruptured implants, and then what tends to happen is you start to form a scar tissue around the implant, and that can also complicate diagnostics if you don't have a skilled radiologist to say, okay, this is due to the rupture of the implant. Usually you see some kind of calcifications and kind of like a star-like pattern when there has been a rupture of an implant and a chronic inflammation in the breast. Now, we've all heard about doing your own home screening for breast cancer, the self-breast exam. I know that the views have changed on that a little bit in more recent times. They're not recommending as much to do the self-breast examination at home. What are your views on that?
Well, when I was initially in training and practicing for the first few years, virtually everyone was told to do a breast self-exam in front of a mirror with the arm up in the air. It was very elaborate, and then lying flat and check for changes in the breast tissue. But what happens is with hormonal changes, you get different densities in the breast for menstruating women, depending on the time of the month, not so much for postmenopausal. Mm-hmm. But they have decided that probably does not significantly improve survival rate or diagnosis.
Right, exactly. And as you and I know, when either of us has done a breast exam in the office, when a patient is worried, they think they felt something, and we've done a breast exam in the office, usually a breast cancer is so small, it's really difficult to find a lump in a breast until it's gotten to a pretty large size. I don't know if you've noticed that, but there are other signs that you can look for on the outside of the breast as well that could indicate there's some kind of problem, right?
Right. If you get nipple discharge, if you get thickening of the breast tissue, with one type of cancer that's a particularly lethal form is inflammatory breast, and there the skin actually begins to look like an orange, and they call it peau d'orange skin. Though that's fairly advanced, and the outcome on that's usually not as good as with the ductal or the interductal types of breast cancer.
Right.
But, and look at the symmetry or asymmetry.
Exactly.
You do that without doing a breast. If one breast starts to point in a funny direction or do something different, or you just notice a structural change, that's certainly worth going in, even if you're not due for a mammogram and being evaluated.
Right. Sometimes the tissue or the skin tends to kind of retract a little bit, or you'll notice some kind of like an indentation or just difference in size even. A lot of women already have asymmetrical breasts, or a little bit of a difference between each breast. But if there's any change, you definitely notice a larger breast size on one side, and it seems to be getting larger. You have any, like you said, nipple discharge. As you said, you usually don't see any changes in the skin texture and color unless you have a certain type of breast cancer that's kind of aggressive, as you said, and that's in the more advanced stages of that cancer. Do you notice, do women normally complain of pain in the breast when they do have a lump and it is what am I trying to say? I'm sorry. Do you notice that the women with a lump and pain in their breast, does that necessarily indicate that it's a cancer?
No, you can get cysts, and cysts can be very painful. They're fluid filled. That's where ultrasonography comes in and plays such a huge role. And if you've got a large fluid filled cyst, it can, depending on the location in the breast, it can be uncomfortable. I was speaking to a patient the other day, and we were discussing breast pain, and it is not the norm. Most lumps that are found are not painful. They are too small to be felt, but by the time they are palpable, you can get some pain just due to the pulling on the local tissue.
Correct. And also you get the fibroid type cysts in younger women. Younger women often come to me and they say, I've got this lump in my breast. It's a hard lump and I'm worried about it. And they might be in their 20s or their 30s. And it seems to come along with the menstrual cycle that some women form these fibroid type cysts, and they tend to go and come back, correct?
That's correct. That's why with breast self-exam, when they were recommending them monthly, they had you do them at the same time of your cycle, of your menstrual cycle every month, so that if you were developing these fibrous type inclusions, that they felt the same on each month.
So when do you recommend that a woman go to her doctor? What kind of signs or symptoms do you recommend that a woman should go to her doctor to be examined, to order a mammogram, and to rule out any major problems, any cancers or anything like that?
I would say if you're symptomatic at all, if you see any discharge, skin retraction, dimpling, anything that's out of the ordinary on your breast, that's a get in there and get it done. I would also recommend in any woman over 50 that they get a screening mammogram. If they have an implant or have had anything done to the breast, any prior surgeries, get a diagnostic mammogram. And I don't know the procedure down here in terms of ordering one. In the States, typically they do a screening. If they see anything suspicious, they follow up with an ultrasound and then a diagnostic.
It's about the same here. A lot of times if I send a patient down, the radiologist will read the mammogram and they will make their recommendations. Now, in addition, if I see anything on there, or if I know anything about the family history, or if I felt a lump that I'm concerned about, even if it doesn't come back on the mammogram, because the mammogram doesn't pick up everything, as you know. Sometimes the mammogram itself can miss something. I did have a patient once that I did send for a mammogram because she did have a lump there. The mammogram didn't show anything, so I went ahead and sent her down for an ultrasound, and lo and behold, the ultrasound did find something, but in the opposite breast. It wasn't what I was feeling. What I was feeling actually did turn out to be a mastitis. And to differentiate that, sometimes you need to go ahead and go further in the studies. For example, as you said, the ultrasound first, and then probably a diagnostic mammogram. And the diagnostic is just basically a few more different kinds of views, correct?
That's correct. It takes longer, there are more views, and then if they see anything on that, they typically will move on to a fine needle aspiration.
Correct, and do the biopsy. So we have an older population here. Until what age, more or less, do we usually recommend that they keep doing mammograms?
That's been an up and down issue for quite a few years in some of the journals that I'm reading. A lot of people are recommending after 80 you don't do screening mammograms any longer.
Uh-huh.
I would say it depends on the viability of the patient. If you've got an 80-year-old that's vibrant, not doing, that's not leading a sedentary life, that is, I'm not talking about a nursing home population, but I'm talking about the average 80-year-old in Boquete who's out and about.
Right.
I would probably still do a screening mammogram on them.
Yeah, I feel the same. But on the other hand, if you have a patient that is maybe suffering from other conditions, not doing too well, stuck in bed or in a wheelchair or something, might not have a real long life expectancy ahead of them, would you recommend they still go ahead and do regular screenings?
I personally would not, but then again, there are ethical issues, and where do you limit health care?
Exactly.
Do you say that this person, just because they are in a wheelchair or they have limited capacity, I think then you just get into a no-win moral and ethical dilemma.
I think so too, and my personal belief is, as long as the patient and the doctor are on the same wavelength, the same page, and they both decide that the patient could benefit from continuing their screenings, then they should continue to do them. I have no problem with sending an older patient, and I have sent older patients to go ahead and do their mammogram screenings well past the recommended age.
Right. I know a patient right now that's in the United States. She's 89 years old, and she just had a screening mammogram.
Exactly.
So,
it depends on each patient. It's done on an individual basis, and of course, it obviously has to do with the wishes of the patient too.
Absolutely.
That's the most important thing. But definitely, young women from the age about 50 on to 70, 80 to go ahead and get their yearly mammogram to screen for cancer. Even if you don't have a family history, it doesn't just depend on the family history. It also can depend on if you've had children or not, right?
Right. The more nursing you have done, the lower the later your onset of puberty, and the more pregnancies you've had, and the more children you've breastfed, that is a positive factor for you in terms of reducing your risk of breast cancer.
Right. In a lot of cancers, for specifically breast cancer and cervical cancer as well, right?
I'm not sure of the statistics on cervical cancer related to lactation or breastfeeding.
Right.
But, there are other risk
but
factors.
Giving birth, I believe, is a major one for as far as cervical.
Yeah, that I'm not up on that particular statistics.
Mm-hmm.
But with breast, there are so many other risk factors, like patients that are overweight,
Right.
that eat a poor diet, that
Mm-hmm.
don't exercise, smoke, alcohol use. These all contribute to your propensity towards developing breast cancer.
Right. There's a lot of external factors, and then there's the big one, the big controversy, the hormone replacement therapy.
Right.
Which we won't get too much into, just that they have found that in some cases, high amounts of exogenous, in other words, not produced by the body, estrogen can contribute to breast cancer. Like I said, we won't go into that a whole lot, but because it is very controversial. But
it's a very complicated discussion. But it still goes back to when they're doing your staging and they do the estrogen receptor staging, which kind of backfeeds into that.
Right. And as we know, if someone has had a breast cancer, then obviously the levels of estrogen are very, very important during their treatment and recovery and their course of disease.
And their course of treatment. When they do the pathology studies for breast cancer, they do what's called the HER2 status. And it's a growth factor receptor that's found on the surface of the breast cancer cells. And this wasn't developed this technology until about the 80s. And It's made a tremendous difference in treatment and knowing what to expect with the patients.
Yeah, you're very right. And it's also contributed to bettering the outcomes. Breast cancer, although it's one of the major killers of women in the United States and all over the world, it's not that death sentence that it used to be. You hear breast cancer and the first thing you think is, oh boy, how long? But when you catch it early enough, and depending on the type, we have so much better treatments these days, and we know so much more on how to treat it. The survival rate after having had a breast cancer has gotten so much higher.
Oh, it's astronomically improved, and they've now determined if you've got the HER2 breast cancer positive, that because of the receptors on the cell, in addition to using chemotherapy, they also use a drug called Herceptin, which binds with these receptors and makes the disease less lethal, makes it less apt to grow as fast. The cells can't multiply as rapidly once their receptors are interfered with the Herceptin. So they've come out with a lot of genetic treatments to modify some of these diseases.
Yes, we have so much better treatments. There's some women out there that say, oh boy, well, I don't know if I ever get diagnosed with breast cancer, I don't know that I even want to go through all this treatment. It's got so many secondary effects. I'll lose my hair, I'll be sick all the time. But really, there has been so much improvement in the treatments, in the treatment outcomes that, especially when breast cancer is detected early, it's definitely worth it to seek treatment. And each treatment is different. Just because, your mom or your sister had a certain kind of breast cancer with a certain kind of treatment doesn't mean it's going to be the same for you.
No, as time progresses, it's probably going to be totally different because we've got so many more staging modalities. And even if somebody comes and says they're HER2 positive, which tends to have a worse outcome than HER2 negative, they still will do estrogen and progesterone receptor testing on everybody. Mm-hmm. And that gives them a further modality other than just the Herceptin by giving them they're actually called anti-estrogen compounds to block the estrogen and slow that growth down. So they come out with so many things. Exactly.
They know how to kind of cut off, so to speak, the food supply to the tumors. And that helps tremendously in slowing down the growth of the tumors and stopping the spread of them, too.
Right, and these drugs don't have the side effects. When you're talking about Herceptin and some of the estrogen blockers, they don't have the side effects that people typically associate with some of the more aggressive chemotherapeutics.
Right. That you're talking two completely different types of treatments. The chemotherapy, obviously everybody knows chemotherapy. Nobody wants to go through that. But you're talking about a completely different type of treatment that targets different types of receptors on different cells. It's not killing, both your good cells and your bad cells. It's actually targeting a certain receptor. And
right, but that's normally an adjuvant to traditional chemo.
Right.
They get the traditional chemo, but then they get the adjuvant therapy that makes the chemo so much more effective.
Right, and a lot of them continue to do therapy well after they've been in remission as well, to make sure it doesn't come back or just to keep it in check.
Correct. And they do annual screenings, they do bone scans, there's a lot of scanning that's done. They do a lot of PET scans, and they just make sure that, for the first 5 years, you don't have any recurrent disease.
Right. Those first 5 years or so are the most critical, obviously. Those are those first 5 years are when we'll find the most relapses or recurrences, as we call them. And it's really important to continue with your screenings, your treatments, and especially if you are in remission, to look for any changes or any signs that possibly you're having a problem in that same area. What about mastectomies and lumpectomies and that kind of thing? Are they still using that pretty regularly as treatments options as well?
I was talking to them up at Moffitt Cancer Center when I was there about 2 years ago. I spent some time on the breast cancer center just looking at what they were doing that was different. It's all research. Mm-hmm. But a lot of them are moving now towards, depending on the diagnosis, and what's happened now with the more accurate screenings is they're diagnosing something called ductal carcinoma in situ, which mm-hmm. means it hasn't expanded beyond the duct. It's all in the duct. And this wasn't even diagnosed 10, 12 years ago. This is a new diagnosis. It's a precursor to stage 1. Mm-hmm. And some people are calling it stage 0, just ductal in situ. But with those, I've seen people that have had mastectomies because they thought that was their best option. Right. They felt better about it. And then I've seen others that just have a lumpectomy and radiation therapy to that area. And if the sentinel node is clear, which it's going to be if it's in situ, right, they don't really require much more.
Right. In situ just basically means it hasn't spread to any other organs in the body. It hasn't spread to any of the lymph nodes and that kind of thing. For those that aren't too familiar with the wording, and normally, I was reading on some of the studies as well. Some are just kind of keeping an eye on it before they actually. I mean, they'll do the node biopsy and all that just to be sure that it's clear. But some of them just prefer to keep an eye on it also before actually doing any invasive procedures. Some doctors. But that's also still, like you said, it's a very new concept for the in situ.
Well, that's a brand new diagnosis. They couldn't make that diagnosis 10 years ago. It hasn't even expanded beyond the duct. It is still totally within the duct, so it hasn't really had a chance to go anywhere. Whereas with the stage 1, it's extending outside the duct. It's perforated the duct wall. Right. And so, with each stage, you look at different treatment modalities and different things you may choose as a patient to have done.
Right, exactly. You have much more choices when it's much earlier on than finding it much later in the course of the disease, which is why it's really important to do early screenings. Now, we also said today we were going to speak a little bit about colon cancer. It's another really big cancer diagnosis. There's approximately about 150,000 new cases of colon cancer diagnosed annually in the United States. And it's also the third most common cause of death from a cancer. And in this case, we also recommend starting screening around 50 years old or so. But more recently, they've said even probably earlier, especially in African Americans, and those with a family history, starting screenings around 45 years old. Or if you're having some kinds of signs or symptoms that, are new, such as change in bowel habits, rectal bleeding, blood in the stools, If you feel a mass in the rectum, those are things that we would consider screening a lot earlier if you had any of those signs or symptoms. Um, what kind of exams should we be doing to screen for colon cancer?
Well, I'm a fan of colonoscopies. The preps have changed dramatically. You hear the horror stories about how awful they are, but the reality is that the preps are much better. The medications that they give you to sedate you are very short acting, and you really don't even know you've had it done. It's a very, to me, it's a very benign procedure for the results you get. Um, and once they do, if they do a colonoscopy on you and you've got a clean, pretty colon and you don't have any polyps or any clumps of cells that look suspicious, they tend to clear you for 10 years. If you've got polyps and they find those, they've got little snares attached to the colonoscope, and they can biopsy those and see if any of those are suspicious. And then they do tend to watch you more closely.
Right, right. Polyps are normally benign, and they do remove them during the colonoscopy. They do send them off for a biopsy. And yeah, they do recommend a little bit more frequent, and I can't remember if it's every 3 or every 5, depending on what they find in the polyp. And obviously, talking about frequency of screenings for colon cancer, you also are looking at, a history of inflammatory bowel disease, a history of abdominal radiation, a family history of having had colon cancer. You're going to begin your screenings a little bit earlier and probably a little bit more frequently depending on what they find on your own screening, correct?
That's correct. Normally they recommend about 50 years old. Now I do know for African Americans they're recommending starting some of them at 40, but I've read a couple different articles on that. And I don't really think there's a consensus. As you said, inflammatory bowel disease, Crohn's disease, ulcerative colitis, all of these can increase the incidence of that, as well as family history.
Correct. And we do recommend, if anybody has any changes in bowel habits, a change in the size, the color, the consistency of the excrement, blood in the excrement, rectal pain is another one, or rectal bleeding, or if there is a rectal or an abdominal mass, even something like an anemia that doesn't have any other apparent cause could be an indicator of some type of cancer, and a lot of times it could be due to a colon cancer, correct?
That's correct. And once again, it's the same as breast cancer. There are predisposing factors. Diet, typical Western diet, is much more at risk than Mediterranean diets. Low fiber, high fat, sedentary lifestyle, diabetes. Diabetes increases the rate of colon cancer, and I think diabetics that are on insulin or have an insulin-resistant diabetes should be screened perhaps earlier. Obesity, smoking, alcohol use, all the just the typical
the typical risk factors
for any cancer.
Correct. We see a lot of people that are afraid to get a colonoscopy. They think they're scared that they'll have a bowel rupture, that they'll pierce the bowel, that they'll get some kind of infection, that the equipment isn't sterilized, that something will go wrong. What would you tell those people?
Well, I mean, I hear this all the time when I try and get people to go in and have it done. I think that, your risk of a bowel perforation is significantly lower than your risk of colon cancer if you're high risk. And I think it depends on who does it. You all can always ask your physician their qualifications. How many colonoscopies have you done or do you do? Is this something you regularly do? And it's an informed decision for the patient.
Right, exactly. They have to I mean, you can't force anybody to get a colonoscopy. We can't force anybody to get a colonoscopy. I have a lot of patients that just flat out refuse, not going to do it, scared to do it, and not scared because they're going to find a cancer, scared that something's going to happen during the procedure, scared that it's going to hurt, scared that they're going to feel it. And really, even here in Panama, they do sedate you. The prep isn't that bad anymore, as you said. You know, most times you don't have to drink what they call here lemonade, which is to kind of purge your system. They'll give maybe like a Dulcolax, a couple tablets, one in the evening, one in the morning of the procedure, and only allow you to have, you know, clear liquids the entire day before. And then they sedate you, and they do it. It's quick. You usually don't even remember anything until you're, you know, coming out of it, and you don't even know it's been done.
That's correct. I have my every 10-year colonoscopy, whether I need one or not, and I just had 2 friends that had them. They had no recollection of it at all. Mm-hmm. They woke up and they went out to lunch afterwards. So, and this was down at Maya Lewis, and everybody that's had them done that I've talked to down here has had absolutely no issues and no problems.
Right. I've never met a patient that's had an issue with it. Everybody that's gone to have one done said that, you know, it was much easier than they expected it to be. I think it's the anticipation more than anything that kind of keeps people from going ahead and just going and doing it. It's a safe procedure. I have never heard of a complication from any of my patients that I've sent to get the colonoscopies done. They can find so many things, not just cancers with the colonoscopy, but they can find other issues that might be going on. Like you said, the polyps and other type of inflammatory issues that may need to be resolved. It's a diagnostic tool not just for cancer. So it's really important.
Correct. It's a very valuable tool.
Exactly. It's just like getting your yearly medical checkup. It's very important to go in and get your yearly exams done. Your blood tests to rule out diabetes and liver damage or kidney damage or anemia. It's just considered as part of your normal screening, correct?
Right, and some of these tests that you're mentioning, the screening tests for diabetes predisposes one to colon cancer. If you've got an anemia, if you've got a blood loss, why are you losing the blood? Where's it going?
Right. Anemia is not just there out of nowhere. There's something that has to be going on in the body to cause the anemia. And after you rule out other conditions,
you know, frequently if I've got somebody that's anemic, let's find out why are you anemic. Let's do a stool for occult blood. You know, that's a totally benign procedure.
Right. And I routinely send that as part of the physical exam, general exam, as part of the studies that we do is a stool sample checking for occult blood. It's one of the easiest ways to find out or to suspect something might be going on in the colon.
Right, and I think now a lot of this, you know, it used to be a stigma, I don't want to take a stool sample in, I don't want to do this, I don't want to do that. And I know now there are several private firms that actually send kits, and I've never seen one, to your home and mail order in the U.S., and I don't know about Europe, but you actually send your sample in, and so you don't have to have the, quote, embarrassment of going to, you know, take your stool sample in.
Right. I know that most people just sort of say, you know, I just can't do that. I cannot bring that in. Well, most of the labs will let you bring the little sample cup home. You can put it in a paper bag and bring it in, and that kind of cuts down on the embarrassment. I do have a question here, and it's that someone sent in to me, and it says, is there somewhere in David or Panama that I can get a breast ultrasound? Is the first part of the question. Pretty much, the answer is pretty much in any of the private hospitals. They'll have a mammography machine. I know that May Lewis does. Also, the public hospital, the Women and Children's Hospital here in David also has a mammography that it can be done. The next part of the question is exemestane, an aromatase inhibitor, available in Panama? That's a little bit above my pay grade there. Do you know anything about that, Dottie?
I did not hear what you said.
If exemestane, aromatase inhibitor, is available here in Panama?
I have no idea.
Yeah, I'm not sure myself. As a general medicine physician, we don't work a whole lot with the different types of treatments for different cancers. So I can't answer that question. But as far as breast ultrasound, yes. Normally, to get a breast ultrasound, you can't just go in and ask for a breast ultrasound. You have to have a doctor's order and a reason why it's being ordered. Because the correct order, obviously, as we were talking about earlier, is that you get the mammography, and then if there's anything suspicious on there and it requires further study, we go ahead and do the breast ultrasounds.
Right. And, they may, I don't know, I don't really understand their question, but I don't know if they're referring to drugs like tamoxifen or what they're talking about. I do know that I've talked to people down here that have gotten drugs that reduce the production of estrogen and progesterone.
Right, they do exist. They do exist. I'm not familiar with this particular one, but yes.
All the aromatase inhibitors are a group of drugs that inhibit aromatase, so that you don't produce the steroids or don't produce the estrogens.
Right, exactly, and it goes to, again, as we were talking before, prevent the tumor from growing. But as far as the different ones available here, I'm not sure of all the different ones available here.
Yeah, I don't know.
Right. So as far as we were talking about colon cancer, which is really one of the more common cancers in the United States, and it's about ranked 5th most frequent types of cancer here in Panama. And it does have a lot to do with especially your diet, not getting enough fiber, being a smoker or even a former smoker, you're still at risk. Drinking alcohol, we know, leads can predispose you to certain types of cancer. Eating a lot of processed foods, canned foods, and hot dogs and sausages, preserved type foods can also be one of the causes for just about any type of cancer, but particularly colon cancers. As well as, like you were speaking about, diabetes. Diabetes does predispose you to a whole lot of other types of issues, health issues. Now, once somebody sees blood in their stool or blood on the paper after they've cleaned themselves, there's other conditions too that can cause rectal bleeding, correct?
Bright red blood to me is the least worrisome, because typically that's lower, very much lower, or else, so you're not looking at an upper GI issue, you're looking at something near the rectum, and frequently that's just hemorrhoids, and that's something you can go in and see you or whoever your family doctor is, and you can do a digital exam,
right?
And you've got hemorrhoids, and then it really relieves the patient's anxiety, rather than sit there and go for 3 weeks with bleeding.
Exactly.
4 drops of blood in the toilet. 1 drop of blood in the toilet looks like somebody's been massacred.
Exactly, and it freaks a lot of people out, and I'll get pictures, and they'll bring it in, and it does. It's scary looking, isn't it? But normally, if it's bright red and, like you said, a couple drops, and we're not talking clots and that kind of thing, we're talking some drops of blood, it can indicate maybe a fissure. An anal fissure. It can indicate possibly a hemorrhoid, or just any little broken blood vessel. Constipation is a major cause of hemorrhoids, as well as some rectal bleeding, right?
Right. There's just a lot of simple things that it can be. So rather than agonize and worry and lose sleep, go in the next day or make an appointment and say, hey, look, I've got bright red blood per rectum, and it's, what can we do about it? Get evaluated. You can do, if they're really concerned, you can do a hemogram and see if they are, how much blood's actually been lost.
Mm-hmm.
It's a very simple workup.
Yeah, it really is, and a lot of people are just scared to do it. They think rectal pain and blood is immediately cancer or something like that. We know that that's not true. We know that other abdominal pains, other type of colon problems, inflammatory conditions can cause some bleeding and some pain. The main thing is if you notice anything different bathroom habits, blood, pain, a mass, it's always best to get it checked out. It's probably not cancer. It could be something that's easily resolved, and you'll put your mind at risk if you come in and get it checked out as soon as possible, instead of waiting. The worst thing you can do is wait.
You make yourself crazy. You make those around you crazy. And another thing you can look at is, I don't know a delicate way to say this, but when you have a bowel movement, normally they kind of look the same. They're round or cylindrical or whatever.
Right.
But if you start to get differences in the diameter of the bowel movements, if they get really thin or you notice that, sometimes that can be a symptom of a colon mass that is moving the fecal material over to the side so it doesn't have its usual presentation.
Right, exactly. And also sometimes because of a mass or something inside of the colon, you can also start, instead of having regular bowel movements, you might start getting diarrhea instead, because you're not getting the feces passed through the colon correctly, and instead it comes out as more liquidy or softer type of stool. So yeah, you definitely look at the size, the shape, differences in what you normally see when you use the bathroom. And most people do probably check before they flush anyways, so they know what their normal is. And also, as we were talking earlier, since we're wrapping up the show, in as far as breast cancer and breast screening goes, obviously the patient, I've noticed, and I don't know if you've noticed, it's usually the patient that notices first that something is going on with their breasts. They usually come to us saying, I felt this, or I've got a pain here, or this one's bigger than the other. It's usually the patient that brings it to our attention first. And as soon as you see anything different with your breasts, any secretions coming from the nipple, any change in size, you notice a lump. Some people just get a lump. All of a sudden they feel this lump there and they're worried about it. Come on in. We'll work you up and rule it out, or get you the treatment that you might need, right? But just don't wait. The most important thing is to get there early and get it diagnosed early and get your treatment early.
Absolutely. Early diagnosis is why the breast cancer cures are so much higher than they were even 20 years ago.
Exactly. And the same with colon cancer. We're able to detect it much sooner and treat it much sooner. And I mean, your chances of survival with colon cancer these days is excellent when you do your screenings and they catch it early. It's definitely beneficial to do your screenings, your yearly screenings in the case of your general health, your yearly screenings as far as mammography and getting your pap smears done. It's important to catch these things early, get them treated early. Your outcome and your survival rate is going to be so much better. You'll have to go through so much less agony, pain, if you start treating it early. There's so many more treatments available to you when it's caught early. Would you like to add anything else, Dottie?
no, I think you just about covered it. But I would say a real easy breast test is once a month, once every 2 months, stand in front of your mirror and just look at the symmetry, get an idea of what your breasts look like. If the symmetry changes, if you've got one nipple that usually pointed out straight now points to the side, or if you've got some nipple or some dimples or something like that, some indentations, it's very simple. It's non-invasive.
Right, exactly. It's a simple way to see changes of your breasts. It's a simple way to say, okay, something's going on here. I got to get to the doc so that they can send off for some tests. And you know, the main thing is get it done early. Scared, not scared, get it done early. I've sent many people during this time. They've told me how impressed they are with our facilities, getting different studies done, how safe they feel in them. They are not worried when they go in. They are screened, you know, for the COVID, and they clean facilities. They take their temperatures, they make them disinfect their hands. And there's not a whole lot of people in the building, so it is safe to go in and get these studies done, especially if you found some kind of change going on. So I'd like to thank you, Dottie, for being on the show again. We love having you here, and you're always a wealth of information.
Well, thank you. I enjoy being here, but it's really different sitting in my house and talking to you via WhatsApp.
I know. Well, as soon as they lift the restrictions, then we'll have to have you on in person again.
Sounds like a plan.
All right. This is Radio Chiriquí 103.3, and this has been Talking with Your Doctor, Hablando con Tu Médico. I hope you enjoyed the show today, and we will be back next weekend from 10 to 11 a.m. For any consultations, you can get a hold of me at 6507-4299. Thank you very much. Have a great weekend, guys. Fuimos bastante bien.
Sí, excelente. No, hubo un par de momentitos que de repente como que la conexión falló, pero
regresó casi de una vez.
Casi de una vez.